I'm Indraneel Roy, founder of Dezy, and today we are very excited to have Rebecca Baker with us for another episode of our podcast. We're here to ask her a few questions to demystify how AI and technology are improving value-based care and patient outcomes for our audience. To quickly introduce Rebecca, Rebecca has been a nurse, a director, a chief clinical officer, a CEO, and an advisor with decades of experience specializing in healthcare technology and value based care. Her mission is to leave healthcare better and stronger than she found it. Thank you, Rebecca, for joining us.
Thank you. I'm glad to be here.
How do you feel to be here?
I'm always excited anytime that I can further the mission of improving healthcare and making it work for everyone. So I'm honored by the opportunity to share some thoughts with you and your listeners.
Thank you so much. So let's get right to it. What do you think is fundamentally broken in how we deliver care today from a patient experience lens?
If we're talking about in US healthcare, I need to be clear that that's where I am going to focus.
Absolutely.
It is its fragmentation. What has occurred over the last 20 to 30 years is a shift to more transactional care, and it's pay for the number of services that are offered to a patient's or the number of services that are offered to a patient versus the outcome. What we're seeing now is that shift back because we're seeing skyrocketing price for healthcare services with very little coordination, navigation, and facilitation with a patient so that there is a good, successful outcome. What we're doing is perpetuating increased number of services without increasing health and longevity and wellness for our constituents. So, I give you an example of that. I had back surgery 2 years ago. I'm a very experienced nurse. My husband is a provider. When I went for pre-op services, okay, it was a
Mm-hmm.
4 hour opportunity, if you will. I had to meet with the pre-op nurse. I had to meet with anesthesia. I met with my own services, my own surgeon, and then with the hospitalist. That's 4 different entities that I needed to meet with. And they asked me the same questions. And finally, the third time in, I said, wait a minute. Why don't you just read what was documented? And I knew what they were going to say. They said, well, we don't have access to the same systems. And I said, why not? You're all covered entities with a need to know. And they all went, oh, you know that lingo? Yes, I do. Why are you one of the largest centers in Nashville, Tennessee, in a city wrought with healthcare services, and yet you've got me sitting in the same room answering the same set of questions for 4 different entities who have the need to know? It's all disparate information. And I said, what would you do if I had dementia? I could answer all 4 of those equally different ways. And then you are no better off from a liability standpoint or keeping me safe. So disparate information is one thing that's happened. Our transactional approach that do come in, I'll treat what's going on, and then you keep coming back and we'll treat everything independently. But we as human beings are a plethora of health. There is a lot going on with us as we age, especially, and
Mm-hmm.
little 10 to 12-minute visits don't cut the ability to deliver good contiguous health care.
Right, right, absolutely. So, how do you define a satisfying patient journey in the context of value-based care?
Oh, that is a segue from what I just said.
Right.
Carefully orchestrated, navigated, facilitated care the way I need care to be delivered. You can deliver personalized, tailored healthcare services to me and the 350 million other people in this country and do it at scale. You can do it on a grand level, but it requires good, careful workflows. I'm a workflow evangelist. Finding out those places where people fall through the cracks and making sure that we as a team put some really tight coordination and connection on there, talking to our patients, finding out what they need from us, finding out how they like to be communicated with. Some people don't ever want to have an in-face visit. Some people want to do just a portal visit or a telehealth visit. We have to look at our patients and what their needs are and what the context of their lives bring with them, those social determinants, and understanding at scale what that can look like from a care delivery standpoint. And as we develop care models, bring in our constituents who are our target patient audience and ask them, bring them into that conversation as we're building clinical models and systems.
Right. That's very similar to the approach of design thinking, but when it comes to this kind of when it comes to patients and there are so many different diseases, so many different kind of treatments, and how do we unify a model that works for all, or will it be, and if it is fragmented, then wouldn't it get fragmented across the experience, also get fragmented across different divisions and different branches of healthcare?
Well, you would think so, but in reality, human beings are human beings that have a disease
Right.
burden, right? We all want to be approached with respect. Whenever we show up in a provider office, we don't want to have like a brand new experience every time we see our provider. That provider needs to know us. So anywhere we go to receive care within the ecosystem in which we live, or the healthcare community that we live in, we have to be able to share data with each other. If we are you mentioned different disease states. I'll give you an example. I could have 10 patients today standing in front of me with congestive heart failure.
Mm-hmm.
They all have the same disease, right? But they don't have the same disease burden. So when we determine what those red flag symptoms are for heart failures, well, it's always shortness of breath and they're fluid overloaded, maybe. But what are the triggers? And what stage heart failure is this patient? A recent echo would be helpful, but if I had it across the county at another hospital or even next door, my own doctor might not get it. So
Mm-hmm.
we're talking about data transference, the ability to tech enable the care that we deliver is critical in delivering precision care at scale. So you could have these 10 patients with congestive heart failure. They all present a little bit differently in their heart failure journey, but the things that set them off, the things that cause them to exacerbate, may be different. And here's a saying I came up with several years ago, and it has proven to be true over and over again. If all healthcare decisions that people make were grounded in logic alone, empirical
Mm-hmm.
pragmatic thinking, we wouldn't have any bad habits. We wouldn't have sick people. But there are other things that drive us to behaviors that cause our disease burden to de-escalate and result in an ED visit. What if we had a team that knew us well, that said, hey, Becky, I know your sister's coming into town. Is this going to be stressful for you? Because I know when you get stressful, sometimes you get your anxiety kicks up and you begin to eat foods that are comfort foods. Let's talk about a plan so that when she comes, you maintain your health and you don't end up in the ED. Let's put a plan in place right now, proactively, with data and good enablement. We have those insights that we wouldn't ordinarily have.
Right. To be able to predict the health trends and
Absolutely.
do predictive care instead of reactive care.
Well, in value-based care, we say proactive prevention with early identification before a problem fully escalates, quick assessment, and swift intervention. Think
Right.
what healthcare could look like if it was approached that way,
Absolutely.
which means
Absolutely.
access, and better insights.
Right. Right. 100%. So also coming back to designing better workflows and experiences, um, healthcare is obviously a very complex setting and a very complex system. So, what are and whenever you're designing a workflow or a system, you're always starting with identifying the biggest pain point. So, when it comes to healthcare and complex care settings, what are the biggest friction points for patients that you identify?
Well, that gets back to the first thing that I mentioned is
Right.
one thing is being known by my provider, having the insights necessary to understand who I am as a human and what my disease burden is. And again, you can have 10 people with the same disease, but their disease burden may be 10 different varieties. More than likely it is. So to be able to tailor the care that's meaningful to us so we don't have to keep going over the same thing every time with our providers, going, oh, by the way, remember, I have this, this, and this. So I need to make sure that we don't do X, Y, and Z. If you have the appropriate information at your fingertips, you can deliver care in a much more swift and meaningful way that does optimize healthcare. It's partnering with your patients. One thing that just irritates me beyond all end is when providers say, I fired a patient. The patient wouldn't do what I told him or her to do. So I just fired him. And I went, in this organization, you work for the patient. We all
Hmm.
work for the patients. Do you know why that patient was not adherent? Well, no, that wasn't really my business that she just didn't do it. I was like, yeah, but it is your business. As a healthcare provider, it is your business to understand why your patients aren't adherent. Is it that they weren't willing to? Or is it because they didn't want to? Or is it because they couldn't? Was there something there prohibiting them from being able to do it? So assumptions about me when I walk in to a provider office, those are big pain points too. When I call to make an appointment, being put on hold irritates me to no end. How can we change that? When I walk into a provider office and the provider comes over to me and immediately launches into my record or what's going on with me, or talks to his computer in his MA, but not to me,
Hmm.
that's a pain point for me too, because I'm a human being. If you keep doing the things that I don't want you to do, like calling me on the phone when I've clearly told you I respond better to text or to emails, not listening, not being invested in who I am as a patient, those are pain points. Having trouble getting to see you. If I have something going on and I want to see you as a provider, and the provider's been telling me, call me when you first get sick, and I do, and you say the window, the scheduling person goes, well, it'll be 2 weeks, and you can say, I may be dead in 2 weeks if I have a person with a really
Right.
advanced disease state. So you're saying, call me, but when I do, then you can't see me for 2 weeks, and there's a disconnect.
Right. Right. Absolutely. So, speaking of this disconnect, how do you see AI and automation being able to reduce this administrative burden and let clinicians focus more on care?
Great question. First of all, AI is a tool. It's not a replacement, right? It is a
Absolutely.
tool to improve efficiency. So one of the first key ways is helping patients get access. So scheduling, you know, going in, getting something automatically scheduled, going in and saying, I can't come on this day and time, what's available next week, and having an AI assistant be able to help with that. And for many patients, that is like a godsend. For some other patients, again, to preference, they want to call and be able to talk to someone, but that person at the desk could go in AI assisted and say, oh, yeah, we have an appointment next week at 2:30 on Thursday. Would that work for you? And it's just like that. So it decreases time, it improves efficiency, and it makes the patients really feel much better cared for and like they're understood, that they're busy too. Another one, when we're talking about HCC capture risk adjustment, that process, to have AI be able to collate multiple data sources including ICD-10, CPTs, and HCPCS, but maybe there's social determinants of health data, maybe there's demographical data that it can collate quickly and present to a provider what's going on with Becky right now today, what it predicted based on people like her over a certain defined period, how her disease burden tends to move without intervention. This is what it could look like in 6 months, a year, 18 months. Um, what is her risk burden? What are the things that we're missing? It can also help a provider understand that maybe I live in a food desert and eating food that's healthy for me and my, maybe let's say my heart failure is not really a feasible option. Maybe we need to have some meal services there where we can control the food that's eaten in her home, or the food that's in her home that she eats. So those are two major ways right there. And the other way, in a tech stack, having AI bots that can collate all of that data and make a really reasonable little visualization for a provider so they can see major key points, that would be wonderful as well. So those are the big ones right now that I see as really driving forward um, that patient experience and provider experience.
Right, right, absolutely. Speaking of access and accessibility to care, one of the areas where we see less accessibility is in underserved high-risk populations. So, how do you see digital tools improve this access?
You know, that is a campaign that I am on right now. That is my soapbox that I'm standing and shouting loudly and proudly. I just joined a university in Tennessee in a grant from the state to create a rural center of excellence. And one of the issues that every state faces, and it's not just Tennessee, is that there are some urban areas where a lot of things are happening, but the majority of the state outside of those urban areas is rural. And sometimes it's mountainous, because in Tennessee, you've got West Tennessee. Tennessee is very wide. Most people don't realize it's as big as it is. But West Tennessee in the Memphis area is very flat. It's farmland, no hill, not a hill to be seen. As you move into Middle Tennessee, it's more hilly area, still very fertile, but not as easy to farm as West Tennessee. When you go from Middle Tennessee to East Tennessee, you've got the Smoky Mountains, the foothills of the Appalachians, and you've got people who have dirt floors and no running water. You have that in Middle Tennessee and West Tennessee as well. But access becomes a true issue. And there are 95 counties in Tennessee, and there are many families that have to drive 50 miles or more to get to medical access. They may not have cars.
Hmm.
They may not have the ability to access that. So, improvement and enhancement of telehealth, increasing our bandwidth. If I can be in the remotest areas of Scotland, in the Highlands, and get a 5G signal, a strong 5G signal, we should be able to do that in our own areas here in the United States. So, increased telehealth, um, making sure that folks in rural areas have a device that they
Hmm.
can have that has built-in Wi-Fi already, that they don't have to worry about an internet provider. It's already built in, and they have good instruction around how to use it. Turning it on, having a video pop up and say, "Hi, I'm so and so, I'm Dr. So and so. I'm with the Music City Medical Center Clinic, and we welcome you to our patient cohort. I'm going to be here to serve you and your needs. My team is here for you. If you need to call me, hit this red button. Hit this red button, and you will be connected immediately to someone. Let's go ahead and get you scheduled."
Right. Absolutely. In one of the previous questions, you had mentioned that for your pre-op procedure, you were asked the same set of questions again and again, and that is probably because all of them were supposed to do that data entry into an EMR, and that was their role to play in that whole process. And we have heard mixed opinions about how EHRs have enhanced care delivery or have made it more difficult. especially because they weren't designed keeping clinicians in mind as much as they were designed keeping payers in mind. And so, in your experience now with this new wave of AI, how do we ensure the tech tools of tomorrow don't add to the noise, but actually solve real problems?
Well, that is the $1 million question, and that could look at 100 different ways, right? Um, First of all, and backtrack, what I was told by each of the four entities that interviewed me is that they didn't have access to each other's systems. And I went,
Right.
why not? You're a designated entity with a need to know. Why do you not? I mean, contractually, you can all be in the same system. You really can. I promise you can. I do this all the time.
Mm-hmm.
Um, but that's the way their setup was, which they all kind of went, when I went, what if I had dementia? And I
Right.
gave you asked me a question, I answered it four different ways. So that will springboard into the question you're asking now.
Mm-hmm.
As AI moves forward, taking the grunt work out of care delivery for clinicians is just incredibly vital. I have configured, built one in tandem with a team. I've configured and taught 10 different EHRs. I love an EHR, said no clinician ever, ever.
Mm-hmm.
I have a ding in my wall where my husband may come home in years past, finished documentation, and something will happen with the system, and he would take his little mouse and throw it against the wall. And I won't tell you what he said, but he was not happy with the EHR when it decided to go down. Um, they are cash registers. They have the ability to be a care tool, but right now it's a checking box. What if we took that SOAP approach, subjective, objective, assessment, and plan, and we created a system that physicians and nurse practitioners and PAs and whoever else was in the care of that patient, the nurses, the social workers, whomever, had the ability to enter data in a way that wasn't checking boxes, but it could see. Here's the thing about checking boxes. This is why this became a big deal. We can't capture the data if it's free form. What if we had
Mm-hmm.
AI bots, and we do, and they're getting more sophisticated to go across written narrative and extract data from it? Then you're letting physicians and nurse practitioners and PAs and nurses and social workers tell the story of what went on with that patient with vital
Mm-hmm.
data being extracted from it, where it could be collated and aggregated at scale. Those have some room to grow. Ambient AI is one tool that is being used now, and ambient
Right.
doesn't recognize emotion and irony and all of the things that human beings manifest. If you were to ask me, Becky, how are you today? And I said, I'm just fantastic. Did
Mm-hmm.
you think I was really fantastic if I said it that way? No.
Not at all.
But
Yes.
AI would document patients feeling fantastic. So
Mm-hmm.
we've got some room in that area to grow. But again, letting clinicians tell what is going on with the patient, even typing it out, and then taking the AI and extracting from it so that we get a good note that will validate whatever diagnoses or what's going on with the patient at the time. And I think that would be a huge, huge win. So data in, or the data out's only as good as the data in. So making sure that the systems that we develop are, we're really stingy about the data that we feed it in a way that we're giving good oversight. We need
Mm-hmm.
compliance around that, because once the data is in there, not only could error, if it's put in indiscriminately, we all know data is dirty as a general rule. It needs to be sanitized and it needs to be formatted, feed it into the engine, and then what comes out is going to be a better product. If not, you're going to have error on clinicians' part. They're going to be given erroneous information, and then it's going to learn bad habits from itself. So guardrails around what our use of AI is for. We need it to solve a specific problem. We don't just go out and say, we're going to just get AI. Somebody told us this AI solution. What problem are you trying to solve? And for clinicians, it is, let me spend time with my patients. Let me
Mm-hmm.
spend time being a doctor or a nurse practitioner or a physician's assistant or a nurse. Let me work with my patient and not focus so much on all of, as my husband says, the data entry, just the data entry.
Right.
We're asking people to do things that's not what they were trained to do. They weren't trained as data entry people. I wasn't trained as a data entry person. I was trained as a nurse. So AI has the ability to help clinicians do what they do best, and that's taking care of people.
Absolutely. Absolutely. So, coming down to another question, how do you evaluate whether a tech-enabled model is truly improving outcomes?
You monitor the outcomes all just closely, and you be willing to pivot at a moment's notice when you realize something is going off rails. So stop, pull your group together and say, all right, look, guys, seemed like a good idea at the time. Something's not working. And let's get to work and find out what's not working. And is it a coding error? Like, was there a SQL line of code that was messed up? But let's get it fixed because this doesn't seem to be matching up. You got to have people constantly looking and testing. And like one of the things that I did with one of my startups that went on to do very great things. I would work with the tech team and the software engineers when they coded HEDIS measures and other quality measures. And I would go in and test in the system with widget patients to make sure that exclusions had been coded correctly, that the qualifications for that criteria or that criteria for that measure had been met. And if it didn't, I would submit a ticket and say, all right, guys, let's talk. We got some issues with this. No
Mhm.
89-year-old woman needs a cervical cancer screen. Don't need it. Something's wrong with the exclusions. We got to go fix that. So monitoring and being ever vigilant, and making sure that what we are building, is built by the people who are going to be using it in chorus with the people who are actually building it. Clinicians and technicians must marry in this work, or it will never work.
Very, very rightly said. Now, coming down to the last two questions, the ones I am personally really excited about. What should care teams and startups focus on now to be future ready?
Tech-enabled care. Delivering tech-enabled care at scale can change populations. Figuring out the hard work, and this is some of my startups. I'm like, look, define your population. Use population health cornerstones. Define your population. What is the problem that they're causing for the healthcare system? That's one question you answer. And is it a problem that we can change with our innovation? And if so, what are the patient issues that need to be solved for while we're working at scale to change it, for our payer partners or for whatever partners we have? What are the patient pain points? I have to address that too. And Lord have mercy, workflows. Sit
Mhm.
down in a group and say, what happens when the patient knocks on the front door or calls? What happens from that moment on? Let's walk through what happens. What is that patient experience? What do we know from our patients who have been talking with us as we're getting ready to build this thing, what their pain points are? Well, if I have patients who don't want to ever be called, and we market what we're doing to them? If they've already told us we don't like this, do we use social media marketing? Do we use different kinds of targeted SMS campaigns? Do we use mailers? Every little question along what happens to the patient. I think in workflow algorithms, do this. Well, what happens? Yes or no? If it's no, where do you go? If it's yes, then what happens? And then next question, what happens here? Oh, three possibilities. Well, what happens with those three possibilities? We have to define it, because
Mhm.
in the absence of clear direction, when people are working in that model, if they don't have clear direction, they'll make it up. In the moment, they will make up whatever to finish the task at hand. But look at what that does to your data. Just that,
Mhm.
if that happens at scale, because there's one little area that you haven't defined in your model, defined clearly,
Right.
then your data is going to be skewed. You won't really know what the outcome is because you didn't have a clearly defined process. And stop firing people, or, just getting on people for doing something that you haven't clearly defined as a business operational lead. When you go back and you say, you know what, we need to define that. That's on me. Let's sit down and work this out. Let's put a system in place. Let's test it, see if it works. So those are some of the key things to address for startups: is knowing your population, knowing your customer, and being very judicious and specific in your workflows. And here's my greatest piece of advice for a startup: start small, miss small, learn great lessons, and then get bigger. But if you try to do too much at one time, your chances of success just really went down. Your minimum viable product is not just a tech, it's not just a tech thing. It is a
Yeah.
clinical model thing as well. Start small, miss small, test it out, see what you've got, get good outcomes, get really good at that, and then build around it. Create a product roadmap for your model and for your tech stack, and make sure that they do this all along those pathways. Roadmap girl,
Absolutely.
workflow girl.
Absolutely. Absolutely. So if you could design the ideal AI powered care experience, what would it look like?
Mm. I think I've touched on some of that, but ideally it would be, I need to see my doctor. And the first thing I'm going to do is call the office. And if I can't talk to someone, I'm going to go online and get a virtual assistant that says, Mrs. Baker, we're happy to get you set up. When would you like to see Dr. Carlicar? I tell them and they go, we don't have an appointment at 9, but we've got one at 9:30. That works for me. I want to be able to have quick access to my provider, which means providers need to expand some ability to see patients and not make it 2 weeks. Because if I am a high risk patient, and my provider's office should know by the data that I am a high risk patient, I do need to have time in that provider schedule to see that provider if something's not going well. So virtual assistant is one way. Making sure my provider has all of the data from all of the places where I go and get care. Well, it's called interoperability. And Renell, let's promote interoperability. You can have HIPAA in place and be HIPAA compliant and still have interoperability, because if I'm the patient and I'm going to need care from these 3 or 4 different places, then they need to be having access to all the data so everybody knows what's going on with me. That's carefully coordinated, navigated care. And that's where AI can help, is in that orchestration and navigation, making sure that information goes where it is supposed to go. Physicians get the messages they're supposed to get from me, from my specialist, from my PT. Everybody has access to what's going on with me, who's involved in my care ecosystem. And AI can be some very much um, advantage there. And I would build those kinds of tools.
Absolutely. Thanks a lot, Rebecca, for sharing your views and answering all of these questions for us. Are there any last notes that you would like to share for our viewers?
When it comes to AI, I think there is a healthy fear level that says
Absolutely.
we have to define what we're using it for. We have to determine what the problem is that we want this thing to solve and go about it in a very judicious, calculated manner with guardrails on what we're using it for and train it just like you do a child or a puppy. Train the AI model with good data, looking for what is it called? The can't think of the word, the falsities that come out of AI, looking for those things, echoes or things like that. It can be a life-saving tool. It can be a game-changing tool for organizations. But knowing what you're using it for and what you're trying to solve that does not include getting rid of staff, it is an augment tool. It's not a replacement tool.
Right.
Help me do my job better, the job that you hired me to do. Give me the tools that make it less burdensome from an operational standpoint to deliver the care that I need to deliver with the tools that surface for me the information that I need when I need it. And that can be for the patient or for the clinician, either one.
Yeah. Absolutely. Thank you, Rebecca, so much for taking out the time to share all your views with our audience, and have a great day.
You too. Thank you so much.